mountains. I've had this happen before, and I think the traffic back home to Boulder is going to be pretty brutal. So I'm trying to get out a little bit earlier today, so it takes only a little under 2 hours to get home versus 4 hours of sitting in traffic. I'm not good with traffic. It drives me a little crazy. So anyway, we're going to get into an interesting topic this morning, and that is, can you use ultrasound imaging to look at decreases in internal jugular vein flow? And if you can do that, could you use it, let's say, to track somebody to see how well they're doing? Now, as you might know, in a lot of craniocervical instability patients, this is a big deal, right? Ultrasounds and other tests like CT venograms are being done looking at internal jugular vein flow. There's some thought that relates to increased intracranial pressure and symptoms. So we're going to get into this because it's an interesting topic and because there's at least one clinic out there doing this. And in fact, when I saw it, I was like, should we do that? We've got 7 or 8 ultrasound machines laying around the office that we use all day that are all capable of doing this. So is this something we should measure? Is it not worth it? So I wanted to get into that today here. So trying a new version here where I actually uploaded all the slides. We'll see how that works. We'll see if it works better than before. So again, today, the topic is, can you use ultrasound to diagnose or track symptomatic IJV compression in CCI patients? And let's see, looks like we do that. So I want you to like, comment, share, and subscribe, because that's how we get this information out to more patients like you. Meaning at the end of the day, if you want to pay it forward in the CCI community to other patients, the best way to do that is to make this content easier to find. And that means liking, commenting on it. If you comment on it, I'll answer your question. And then share, subscribe, etc., because that allows other patients to find this content. If you don't do that, they can't find this content. And I think we all want to pay it forward to other patients, right? You realize how miserable you can be with craniocervical instability and some of these neck issues. And if you want to make sure that you pay it forward to other miserable patients, that's the way to do it. I also have a new site for questions on PICL, CCI, and written answers. That's a subreddit. It's rPICL. And, I was thinking about this morning. There was a time where we used to have, as a society, lots of FaceTime with doctors, right? And think about it. Way back when, even when I was a kid, docs still made house calls. And, they would drive out to your house. Obviously, there was a lot of FaceTime because if they drove all the way out to your house and they brought their little bag, there would be a lot of time to have those conversations. Not so much today. In fact, what happens today is boom, 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 boom. See a lot of patients, do a lot of procedures, not a lot of FaceTime with doctors. So this is your ability to get me to answer your questions in writing online. And it's also creating a nice repository of questions and answers for other patients. So if it's 3 a.m. and you just got to have that answer, you can go on this and look it up and see if someone's asked that question and whether I've answered it. This is a great Facebook group. If you're more interested in one-on-one Q&A, meaning one-on-one Q&A with patients and other patients, asking patients questions, because there's a lot of value to that. This is a great one because this group will really screen things and try to keep the conversation logical. And keep it from sort of careening off the tracks into some of the crazy directions I see it going to on some of these CI or CCI forums that I review. So the first rule of medicine is if you can do no good, do no harm. That's actually kind of a paraphrase of the Hippocratic Oath. It's not really the Hippocratic Oath, but it's a paraphrase of it, and it makes a lot of sense. Now, there are times where complications happen during procedures. There's not much you can do there in some cases, but in other cases, you can. Now, a corollary of that is the purpose of any diagnostic test is to see if the results will alter the treatment plan. And that just makes sense, right? Why would you do a diagnostic test if it wasn't going to change your plan for the patient? But all too often, I think these days, diagnostic tests get due to generating money. And in particular for a private clinic, it can be quite a lucrative source of income. I'm not going to get into the clinic I'm talking about today, but I would estimate that in every CCI patient, it's probably adding $3,000 to $5,000 to the bill by running a suite of tests. We're only going to go into one of those tests today. We recently added a diagnostic test, neck care, which looks at proprioception. We don't charge for it. It's free. It costs us some money, but we don't charge patients for it because it's interesting to us and it helps us diagnose the patient. So let's look at the IJV and CCI because this is a huge topic within the craniocervical instability community. So the basic concept here with IJV and CCI is if the IJVs are blocked without collaterals, and collaterals are those new detour veins that usually form when the bigger veins get blocked, you can increase pressure inside the brain. That's going to cause symptomatic intracranial hypertension, and that's going to lead to symptoms of confusion, brain fog, headache, nausea, etc. So that's the main idea here. Now, this is due to the concept that decreases in IJV flow can be seen if the transverse process of C1 puts pressure on that internal jugular vein. And that's right here. So the transverse process of C1 is right there. It can put pressure on the internal jugular vein. And then you've got the styloid backstopping on the other side. So if you have an elongated styloid, which is really just calcification of the stylohyoid ligament, then it can get, the IJV can get smushed between the two. Smushed, I don't know if smushed is an actual word, but it's one we use a lot. So now we're looking at a cross-section from above, right? I've simplified all of that to try to make it easier to understand. So you can see here, this is the atlas that I've drawn. This is the transverse process of the atlas that I've drawn. This is the IJV on the other side, styloid on this side, styloid on that side. So you can see now that there's this issue of having the IJV living between the transverse process and the styloid. Now, oftentimes what we'll see is rotation in the atlas, and that rotation in the atlas is causing one side of the IJV to get more compressed than the other. And so consequently, usually these patients will get offered at some point a decompression surgery, whether that's removing the styloid. And hopefully, you know from watching this channel that once you remove the styloid, you increase instability in that patient. So we don't want to do that if someone's unstable. Or you can also shave down the transverse process, which again increases instability. So hopefully we don't need to do either one of those things. Hopefully all we need to do is to get rid of the instability. So this is the problem at its worst, and I don't know if this is going to work or not, guys. I'm not quite sure. There's a video here, and I don't know that I can make the video work within, no, I don't think I can. Within uploading, I'm trying to upload my PowerPoint to StreamYard, but I don't think that video works. But what this video shows is that if you turn your head to one side, in this guy, the IJV cuts off right at the atlas, right? So that would seem to be evidence of some sort of significant issue we should all be concerned about. Now, let's take it from there into diagnostic ultrasound of the IJV and CCI patients. And this didn't translate well, but anyway, that's okay. Bottom line is that there's at least one clinic that's offering this diagnostic test. What they're doing is they're putting an ultrasound probe here, and they're doing what's called a Doppler ultrasound, where you can measure flow of the internal jugular vein, and then they're turning the head. And when they turn the head, they're looking at a drop in flow. And then they're claiming that that drop in flow is abnormal and caused by the CCI. Then they're using that to track patients and their results with simple prolotherapy to try to see if that drop in flow improves. So in seeing that, one question I had is, should we be doing this, right? Like I said, we've got more ultrasound machines laying around that I know what to do with, meaning 7, 8, something like that. They can all measure Doppler flow velocities, so not hard to do, but is it worth doing or is it fake? And that's really what we're getting into here. Is this a real diagnostic test that can separate out craniocervical instability patients, or is this just a figment of someone's imagination and the patient is paying a lot of money for a Doppler ultrasound study that's worthless? And that's an important thing for us to figure out. So again, real or fake? If this were real, we would have to have a clear normal metric to say, if the flow drops below this when the patient turns their head, then that's not really found in people walking around out there on the street. So that's probably due to the craniocervical instability in context of a CCI patient. Or is it totally fake? Meaning, can we find lots of people out around walking around on the street right now? If we bring them into the office, we put an ultrasound probe here and we have them turn their head, we're going to see the same thing. So real or fake? That's what this is about today. And this is not going to, I'm not going to be able to play this little clip. I had a Madonna clip here for you. So I guess this is one of the downsides of uploading your slides to StreamYard. But anyway, long story short is this is a 1989 study. The hit that year was Madonna Like a Prayer. This is the same year that Tiananmen Square happens, the same year that the Berlin Wall fell. So we've known since 1989 what happens to IJV flow when you turn your head. It's not new information. Doppler ultrasound hasn't changed since then. It's gotten fancier. The machines are fancier, but it's the same idea. It's the same thing. So nothing has changed since 1989. So it's not like we have to go looking far and wide for information that's recently published. This stuff got published when the Berlin Wall fell. So what I did here is I graphed their normal IJV flow data, meaning they just took people off the street. And this is how I graphed it. You can see here the light blue up top is in 14 patients of 32. They saw a decrease in their flow on that side, on the left IJV. In 18 patients, they saw a massive increase in their flow. And then if the one on the bottom, the dark navy blue, is going to be right IJV and left head turn. So just from being a scientist and working with numbers all day, we publish a lot in my office. This is one standard deviation from the mean range. I can look at this and say, this is junk. It's all over the map. That's why I've got the little thermonuclear explosion there, because as soon as I saw this data and I graphed it, I looked at it and said, you can't make head or tails of this. There's no way you could use this as a normative data set, because for people walking around on the street, IJV flow goes up, it goes down randomly when patients turn their head. So if we look at that in a little more detail here, this is just the one side. So 44% of the patients, their flow went down. 56% of the patients, their flow went way, way up when they turned their head. If we just focus on the 44% of patients whose flow went down, it went down from about 60-something% and on the good side, about, let's say, 7% or so. Now, this is just one standard deviation from the mean. If we take 2 standard deviations from the mean, we're going to be way, way out here. So this is 1 standard deviation from the mean. This is 2. So this is 2 standard deviations from the mean. And so now we're beyond no IJV flow. That means that there's going to be patients who are walking around out there on the street that if you turn their heads, their IJV flow is going to completely stop. So now it just went from ridiculous to absurd, right? You can't use this normative data to come up with a normative data set to try to say that this is an abnormality at all, because it's all over the place. So my conclusions, and this is the post that I did on LinkedIn this morning, is this is a fake diagnostic test. Fake diagnostic test means that if you do it, you don't do it, you're not going to be any smarter after you do this test, because you won't be able to separate CCI patients from people walking around on the street. People walking around in the street, when they turn their head, their IJV flow goes up, it goes down, and in a chunk of those patients, it goes shut off. So we're not going to be offering this at CSC because it's a fake diagnostic test. Why would I charge patients a lot of money for this test that doesn't change the treatment plan and isn't even real, right? It's giving me fake results. The results it's giving me are, I can't tell if I'm looking at a patient or someone walking around on the street. So in conclusion, you can't use a change in flow in the IJV with head turn to diagnose an abnormality. It's just too commonly occurring in normal patients walking around on the street. And that doesn't mean, though, that we don't have some patients who have intermittent drops in flow that can cause symptoms. Perhaps their drops in flow occur more often, and we're not looking at that here. But it probably means that a cutoff of IJV flow is not the primary mechanism for symptoms in CCI patients. And that's a hard one, I think, for a lot of CCI patients to grasp, because they've been told time and time and time again that, you know, this is the cause of your problem. And so let's talk a little bit about that, right? Maybe there's a better model for IJV flow in symptomatic CCI. My sense would be that what we're talking about is a straw that breaks the camel's back type theory. And that is that if you have a Chiari stopper effect, meaning Chiari and other things are blocking the front and the back of the spinal canal, then drops in flow here are probably more dramatic and probably more likely to cause symptoms. If you add in craniocervical instability and other things are sensitized because of that instability, then maybe again, it's making these drops in flow more significant. But really what it comes down to is we're not going to be able to use these drops in flow to track much of anything in patients. And to put it much more simply, you've seen me do this with Chiari before, right? Chiari 0 or 1 is a normal anatomic variant. We can find lots of people walking around the street right now. If we bring them in and do MRIs, they're going to have a Chiari 0 or 1. But when you add Chiari 0 or 1 plus instability, you get symptoms. In the same way here, I think a lot of people walking around out there with decreased IJV flow, which is a normal variant. But when you add instability on top of that, you get symptoms. So in both cases here, the commonality is instability. Treat the instability, and this will become less of a big deal. Okay, that's my talk for this morning. We got lots of questions. I'm able to see the questions this way, so that's the good news. Let me stop the share here. Let's see. Okay, so let's go to some questions. Alexis, what are your thoughts on platelet-rich fibrin for facet joints? Doesn't make any sense, meaning it's not going to add anything. All platelet-rich fibrin is where you've activated the PRP, and the PRP can be artificially activated. The problem with artificial activation of the PRP to get it to clot, which is what platelet-rich fibrin is is that you have lower growth factor release from those platelets than if you just let it naturally clot. PRP will clot. It'll clot due to the presence of free collagen. So you don't have to create platelet-rich fibrin. If you inject PRP into a joint, it's going to clot. And if it naturally clots, it's going to release more growth factors. So platelet-rich fibrin is kind of a dumb idea, meaning it would seem like a good idea. You clot it, and maybe it stays there locally, but it's going to clot anyway. So why do you need to artificially clot it? And if you artificially clot it, you're then going to reduce growth factor relief. So it's a gimmick, nothing more. Alexis, how long does it typically take to notice results from posterior PRP? Alexis, as we talk about, posterior PRP has a broad definition, right? Everything from simple ligament injections with PRP to much more complex fluoroscopically guided facet injections, to those types of facet injections plus PRP, to upper cervical facet injections plus ligaments, etc. So I don't know what you got, but in general, 4 to 6 weeks, I think, should be the maximum time for that kind of posterior PRP. So I wouldn't wait too much longer than that to decide whether or not that's worked or not. But again, there's a broad definition of posterior PRP here. This over here has nothing to do with this over here. They are completely different things. So let me know what you got. If it's just some blind PRP into ligaments, that has nothing to do with the kind of posterior PRP that we would offer at Centeno-Schultz. Raj, hi, Doctor. Hope you're well. You're running a new clinical trials for new EPICL. Nope, still got the same old one running that's a bear to recruit, meaning the biggest problem we have with recruiting it is that we force patients to do 2 PICL procedures with a sham. And when we talk to patients about that, they generally don't want to do that. That's because they're miserable, right? Who would wait 6 months getting nothing, meaning the pretend treatment? And it's been very, very difficult to recruit. And I understand why. Easier to recruit a knee study where someone's got a sore knee versus a study here where we tell you might be in the sham or control group where you're not going to get anything for 6 months. And patients are like, I can't even work. Why do I want to do that? Raj, doctor, if someone had a fusion or disc replacement surgery and any of their cervical spine levels and possibly FCCI, what treatment procedure would we advise they can have safely? Well, Raj, as I think we've talked about before, a lower or mid-cervical fusion is going to put more forces on the upper cervical spine. So that's a problem, right? That means that all things being equal, we've just made the upper cervical spine worse. I can't change the fusion. The best I can do is to treat the upper cervical instability. I think patients like that who have had lower cervical or mid-cervical fusions are going to be harder to treat because they're going to have more forces being thrown into that upper neck. Liam, I think you were talking about diagnostic tests just being done for the purposes of making money, and I would agree with you. As you can see, the analysis we just went through to see if we want to do this at Centeno-Schultz Clinic, and the answer is no. It's a fake test. If you're charging patients for it, you're giving them fake results that don't mean anything. So why would I charge a patient to do that? Wouldn't make much sense. Alexis, what might cause a feeling of pressure in the area where the back of the head and neck meet when someone goes from sitting to standing? About a dozen things, but to go over the top 3, it could be related to any of the upper neck facet joints, 0, 1, 1, 2, 2, 3. That's probably the 1, 2 facet joint. Could be related to swelling in the upper cervical bursas because of the instability, or could be related to one of the occipital nerves, third occipital nerve, greater occipital nerve, lesser occipital nerve. So those are just 3 of the dozen things that could cause that kind of issue, having nothing to do with intracranial pressure at all. Natasha, I notice a pattern. Can you educate why, if I'm not 100% present in movement and relax, I will get elevator drop in head to body feeling, falling backwards, left leg give way? Yeah, Natasha, I think what you're describing is a very good demonstration of what happens when the ligaments aren't doing their job, right? As I've always say, stability is half ligament and half muscle. Now, if the ligament portion isn't there and you go to relax those muscles, you're going to get instability into ranges that cause problems, in this case, problems in the upper neck joints, which are responsible for position sense that goes to the brain. So all of a sudden, your muscle that was keeping everything tight and together relaxes, things get out of place, bad information goes to the brain about position sense. That bad information doesn't agree with information coming in from your eyes and inner ear, so you get this sensation. Yeah, I don't want to get into that, Stephanie. I try to do these as blinded as I can. Sometimes I'll talk to individual patients about it, but in these public broadcasts, I try to stay away from this. I would just say, listen, if someone offers you an expensive diagnostic test using Doppler ultrasound to try to see if when you turn your head, the drop in IJV flow is causing your symptoms, and that's a fake test based on the data. So since it's a fake test, I'd run the opposite direction and don't get treated by that clinic, because they either haven't looked at the data or they have looked at the data. I'm hoping it's that they haven't looked at the base data. Snowmass, WRT, a recent upload in shoulder and CCI relationship. What would be the treatment approach? Yeah, so that's an easy one. You treat the shoulder and the CCI at the same time. I would say that in my patients, probably 1 in 3, some days as many as 1 in 2, but let's say 1 in 3 on average, we're treating something going on in the shoulder and in the neck, because on exam of the shoulder, that shoulder's got issues. So that's the approach. Alexis, are there multiple locations higher dissection can be done for occipital neuralgia? For example, the C2 lamina versus up higher above the hairline. Yeah, so there's multiple locations where you can go ahead and hydrodissect. You can hydrodissect in what's called the rectus capitis posterior major tissue plane. You could hydrodissect the third occipital nerve at the lateral portion of the articular pillar at 2-3. You could hydrodissect the greater occipital nerve higher up near the upper trap insertion. So as you can see, lots of different spots. My styloid cuts it out completely only when I look down. Yeah, so Darcy, that's probably normal. And I know that's hard to conceptualize, that if we take people off the street and we bring them in who have no problems at all, and we have them do that, that we'll probably see the IJV flow get cut off in some percentage of those normal people who have no problems or symptoms. What I would say is that that's probably emblematic of having craniocervical instability. So the focus is fix the craniocervical instability. Knowing that your IJV cuts off inflection doesn't tell us a lot if you've got instability. We're still going to try to fix your instability, hopefully, meaning if you get your styloid cut and you have instability, that means you're going to be more unstable and we're going to have bigger problems, not smaller problems. The Tasha we discussed today, is that why when I could ride a bike, if I turn my head to the left, I would feel like I would pass out, dementia like a... Yeah, so again, Natasha, I think that some of us, if you're talking about before you got injured, some of us do kink off our flow when we turn our heads. And that may even cause some symptoms. So we don't do that often. We would probably know from experience as a normal person, not a patient, that if we turned our head over to the right and just left it there, that might be uncomfortable. So we don't do that. Realize, though, if we did it a lot, we would have collaterals form. We would have little veins form around the big vein to try to keep the flow going. And that's just normal stuff in the body. Natasha, I should elaborate on my head turn and feeling like I die. Come back, question any forward body functional pattern. Gotcha. Alexis, can Chiari only be found in an upright MRI? No, Chiari can be seen on recumbent MRIs. I think it's going to be more likely to be found on an upright MRI. And what I mean by that is that the gravity of an upright MRI will pull the brain down a bit. And so it's more likely to be seen. But again, be careful there because Chiari is a normal finding. And what I mean by Chiari as a normal finding is 0, where it's right at the foramen magnum, or 1, up to 5 millimeters below the foramen magnum. So again, we can take people off the street all day long and twice on Sunday, and we can find lots of people with Chiari malformations who have no problems. They're living their lives. And most people with Chiari malformations have lived their lives until something happened. And then when that thing happened, they started to get symptoms. So just be very careful there. It's probably, again, Chiari plus CCI equals more symptoms. CCI alone would probably equal less symptoms, meaning if you have Chiari plus CCI, you're probably more likely to get symptomatic, but Chiari is not the cause of your symptoms. Honey, Doc, you make things simple. Thanks for being a great person. Well, thanks, Honey. I try hard to make things simple because these are all complex things. And I think many times we doctors use the complex to try to pull the wool, if you will, over patients' eyes. It's a little bit like a magic trick here. Look over here, and what's really happening is over there. So again, the goal is to make things simple so that patients can understand. Anja, Dr. Centeno, what's your opinion on vitamin infusion as part of prehab or rehab for CCI? Addition, is atlas orthogonal, chiro, contraindicated for patients with ponticulus? Let's break it down. So vitamin infusions as part of prehab or rehab, we have no data at all that vitamin infusions move the needle at all with regenerative medicine injections. I would take vitamins, certainly. I would eat healthy. And if you maybe have some sort of specific severe vitamin malnutrition or deficit, maybe that could be helpful. But for the average person, no, it's not going to move the needle. We have no data that shows that it moves the needle. So why would we do it? Would make no sense. And I'm going to stop here, guys. If you've just joined us, please hit that like, share, subscribe button, just because that's how you pay it forward into the CCI community. As you know, you can be quite miserable as a CCI patient, and you got to help the algorithm find this content by clicking that like button, because that's how you pay it forward to other miserable patients out there, because there's going to be more. Once you get your problem resolved, 3 months from now, 6 months from now, 9 months from now, 3 years from now, there's going to be someone out there who's miserable, who's not going to be able to find this content because you didn't hit that like button. So please do that now. Andreas, what do you think of the idea that increased intra-abdominal venous pressure from compression there explains why some IJV compressions are symptomatic while most aren't? It's an interesting one. I haven't looked into it. I'm happy to look into it. I'm not quite sure why anyone would have increased intra-abdominal venous pressure unless there was some other abnormality there, right? It's certainly possible, for example, in HEDS patients who have, maybe 10% of those patients who have vascular abnormalities in that region to have something like that. But for the vast majority of us, that wouldn't happen. So interesting idea for sure, but I've not looked into it deeply. Liam, if a patient is in a neutral position, has significant compression of the IJV, is that more of a concern? It's not, Liam, regrettably. There's another video that I have, and let's see if I can find it or not here. Let's see. So guys, if you are on YouTube, let me go ahead, Liam, and try to find that for you. Okay, so if you're on YouTube here, you can just go to my channel. It's easier for me. It says view your channel. It's not going to be so easy for you guys, but this is my YouTube channel at Centeno Home. And then you can search here. You can search the channel. So I think it's probably under internal jugular. Let's type in jugular and see what we get. Here we go. There's a bunch of these videos on that concept, Liam, that go through the data that shows that, again, there's a lot of people walking around that have static IJV compression. So the answer is not that big a concern, certainly from the standpoint of having it decompressed. Now, it may just help us understand maybe that why you're getting intermittent symptoms, because the instability plus that is causing symptoms, kind of like I said before. But that's how you would go find it. There's a bunch of different videos there for your watching pleasure, if you will. I haven't said that before. It's kind of an interesting sound to it. Your viewing pleasure, I think, is what it would be back in the day. SNOMAS, if you have a large disc bulge, 4 to 5 millimeters, recommended for surgery, but also have extensive ligament damage causing CCI 1C, would that recommend for treatment priorities, assuming CCI? Yeah, so it all really depends on what's causing symptoms, right? So this is a classic one that I've gotten into before on lower cervical problems. Let's see if you can find it here. Lower cervical versus upper cervical. Let's go through that, right? Mid and lower cervical symptoms are things like pain in the neck, pain in the upper back, numbness and tingling in the hands. Now, upper cervical symptoms can include those, but also has specifically related to upper cervical things like headache, imbalance, dizziness, other autonomic symptoms that come along with CCI, tachycardia, POTS, etc. So we have upper cervical symptoms and lower cervical. So if your symptoms are primarily upper cervical, the ones that really disable you, then that's the focus of treatment. We can also treat the lower cervical disc bulge when you come in for treatment of your CCI. We do that all the time. Now, we certainly have CCI patients that we resolve their CCI and they still have issues related to that lower cervical bulge. And since we've treated a bunch of times with interventional orthobiologics, it needs surgery. I haven't seen all that many of them, but they're out there. We've seen a couple. So again, it just depends on what is causing your symptoms as to where you go first. Can traumatic damage of the LFTCL of ankle in combination with long-standing walking cause nerve damage in the foot. So basically, to simplify it, can lateral ankle instability cause nerve damage in the foot? Certainly, you could get irritation of the descending branch of the calcaneal nerve that comes off the tibial nerve. We've seen that, and those patients end up with numbness in either the medial side of the foot or the heel. It's possible that it could aggravate the tibial nerve as it goes to the tarsal tunnel on the other side, on the medial side. So yeah, it's possible that those two are created. Certainly, the instability isn't good. The instability is going to chew up the tibiotalar joint, so you're going to want to get that treated first, and then you can obviously also get the nerve treated at the same time if you're using orthobiologics. So you would do a focused injection under ultrasound guidance of the lateral ankle ligaments, in addition to a hydrodissection of the nerve with platelet growth factors, because we know that platelets have nerve growth factor and can help with nerve repair based on the existing randomized controlled trials. So bottom line is, I would treat both with interventional orthobiologics and see what happens there. Stephanie, how does PICL benefit compressed IJV? CCI and AAI have been ruled out. Well, the only reason we would do PICL is for CCI or AAI. And compressed IJVs by themselves usually don't cause symptoms. So if someone has tried to convince you that your compressed IJV are causing symptoms, that's probably not correct, because we can take a lot of people off the street who have compressed IJVs and no symptoms. And then the question is, what is causing your symptoms, right? So if your symptoms are headaches, there's a dozen different things in your neck that can cause headaches. So we would want to identify what those things are and treat those things. So let's take pain right at the back of the head that goes like this. That's usually the C1-C2 facet joint. You target the C1-C2 facet joint on physical exam. Oh, yeah, that's tender. Yeah, doc, that causes my headaches. You then take the patient back to a fluoroscopy suite. Use fluoroscopy in addition to contrast confirmation, digital subtraction angiography to safely get into the C1-C2 joint. You put a little PRP in that joint, see if the headaches go away. All of that having nothing to do with compressed IJVs, because your neighbor down the street probably has compressed IJVs. Very important to understand. Doctor, in your reply, you would still offer treatment, but it might be more complex. It may take longer to resolve. My reply. Let me go back here, Raj, and see what we were talking about. Yeah, so I think you were talking about a mid or lower cervical fusion and how you treat CCI. So I would agree. Really still treating the CCI, but it may take longer to remit because of the increased force from the fusion. Stephanie, does DSA and BTO balloon occlusion are the good test to measure pressure gradients? You could do I think what you're talking about is trying to measure, just so everyone else understands here, because we're deep in the jargon now, measure intracranial pressure at the site, right? Oftentimes, we just measure opening pressure with a lumbar puncture, and that's not all that accurate because at the end of the day, the pressure down there might be lower, it might be higher up here. So you're talking about floating a balloon catheter, occluding and measuring pressure. And you can certainly do that, but what do you do with that information? Meaning that if you have slightly increased intracranial pressure and the pain is still coming from the C1-C2 facet joint, one has nothing to do with the other. One's not causing symptoms at all. The other is causing your headaches. So again, probably much easier and safer to inject that 1-2 facet joint if it's tender on exam and seems to be what's causing the headache, than to float a catheter through the groin up into your internal jugular vein, deploy a balloon and measure pressure. One is about an order of magnitude safer than the other, the C1-C2 facet injection in experienced hands versus the balloon venogram with pressure. I must be CSF leaks if I don't sleep with hard cervical collar on. Yeah, so Darcy, the first question would be is how do you know there's CSF leaks, right? And that's a hard one because CSF leaks are very difficult to diagnose. Now, if what you're telling me is that you get CSF leaks that can easily be seen on MRI when you don't wear a hard cervical collar, then the question becomes, are you just a chronic leaker that has to do with collagen, or do you have that plus instability? Sounds like you probably have that plus instability. So again, the focus is get rid of the instability. I don't know what that one means. I think we got a bad translation there. So maybe ask that question again. Natasha, I just completed all the paperwork and sent off from the latest imaging to ICS yesterday. Have an SI lumbar knee next weekend. Super excited. Great, Natasha. Happy to see it. What Natasha is talking about is if you're interested in seeing me for a telemedicine, what you can do is to contact the Centeno-Schultz clinic. I wouldn't contact Regenix. I've seen a couple people get into the rabbit hole there. That's a different company. They have a different call center. Contact Centeno-Schultz clinic. And you'll eventually get to ISIS, who will help pull all your information together. And then we'll get on, and then there'll be a pre-review to try to make sure that you have enough information for me to give you an answer as to whether or not I think you have symptomatic craniocervical instability. Obviously, if you don't have enough information, it's going to be a waste of your time and my time. So we try to then tell those patients, hey, you got to get this and that first. But assuming you get past that screening step, you'll get online, face-to-face with me in a telemedicine, and we'll go through all of your history, all of your imaging, and I'll ask you a bunch of questions, and I'll try to get to, do you have symptomatic CCI? Is it the kind that we can help, or do you need surgery, or do you need something else? Yep, I think I got that one already. Anja, if flexion provides relief, but going to extension aggravates, could this be a manifestation of IJV compression or not? Yeah, I would say that would be the least likely thing to be a manifestation of IJV compression, meaning that there'll be a lot of other things to explain that, Anja. So let's just talk about one, because we just had a patient who was talking about CCI type 1C. CCI type 1C is where the skull slides, right? And many of those patients, when they go into an extension, have their skull slide backwards on their cervical spine. So that can cause lots of symptoms. The 0-1 facet joints are not going to like that. They're going to get pissed off. They're going to get swollen, and that's going to cause headache, for example. Now, the way to treat that would be coming, again, anterior in that PICL procedure to treat the anterior AO ligaments, to treat the other anterior ligaments that help to stabilize the skull on the neck when you bring your head into extension. Liam, are there certain shoulder issues that you see with your patients? Yeah, Liam, the biggest one I see time and time again is AC joint instability and SC joint instability. That's a super common one in the CCI population. And those are at either end of the clavicle or the collarbone. This one connects the collarbone to the chest. This one connects the collarbone to the shoulder blade. And that one is super common. So when we see those and they're significant, assuming the patient can tolerate it, and that's 80 or 90% of the time, we treat those as well, because those are, I have another lecture on this, but those are the bases of support for the whole cervical spine. I call it the cervical pelvis, and others have called it the cervical pelvis, meaning your SI joints tend to be helping to stabilize your lumbar spine, and these joints tend to help stabilize your cervical spine. So we treat them all the time when we find them. Andreas, can facial swelling and a feeling of facial fullness while bending over be an indication of venous outflow issue or CCI in general? You know, it can, and it could be related to IJV compression that's happening intermittently in flexion. It could be related to trigeminal neuralgia or the trigeminal nerve that's getting irritated in flexion. So again, different things, but yes, that could be what you're describing for sure. Hannah, Dr. C, I've got 1-2 instability. Had vascular study done on my jugular vein, sits very high. I've been told by a neurosurgeon I have high veins. Yeah, Hannah, I'm not concerned by that at all. I don't even know what high veins means, meaning at the end of the day, there was a time in your life where you didn't have any problems. Unless you were born this way and you've had this kind of problem since you were born, the vast majority of patients would have something that happens in their lives, and then all of a sudden this becomes symptomatic. So again, the focus is still trying to fix the craniocervical instability. Now, in context, I would certainly love to look at your case. I'd love to look at your imaging. I think you contacted me via email, so I'm happy to look at all of that and try to see if any of what you have been shown would change any opinion. But I think in general, it's not going to be a concern. We're still in the game of trying to get rid of the instability. Great, Darcy. Happy to look at all your information. Again, what Darcy is talking about is doing a telemedicine where we can look at all this stuff in detail. What's going on with you? What does your imaging show? I can ask you questions about X, Y, and Z and can come to some conclusions about, can we help? Do other things need to be done? Is it surgery, etc.? Mr. Nick, if I get AO Chiro and after a month, Atlas has stayed in, symptoms better, but only about 25%. Pulsatile tinnitus, uneven pupil, brain fog remain. Could there be instability even if Atlas is now aligned? Yeah, so realize that the fact that you go in there one day and they say the Atlas is aligned doesn't mean that the Atlas isn't slipping out of place when you're doing your daily activities and then slipping back in place when you're not. So again, remember, instability is a movement-based concept. It means that when you move, this particular area moves out of place. If you're not moving, it's usually not moving out of place. So again, one doesn't really preclude the other very much. Raj, doctor, thank you for the MRI flexion extension protocol video you put out. I will help people worldwide. Yeah, so what Raj is talking about, and this is important, right? Because what I try to do is to put out enough information that if you never ever see me, or if we never even talk one-on-one, what I've put out has helped you in some way. And what Raj is talking about is the X-ray stuff here. Let me go ahead and pull up that video and see if I can share it. This will take just a second, guys. Okay, so let me go and pull up that video here because this is an important one if you're out of country, right? So if you're out of country, I did this video on how to use X-ray and DDR for CCI diagnosis. And the goal here was to try to create a video that the imaging center could watch. Obviously, as a patient, you can learn some things here, but the focus is the imaging center. Could I get a video where if you gave it to the imaging center, the rad tech or doctor would watch it and they would say, oh, I understand what this guy wants. I can try to do that using regular X-ray. So this patient doesn't need a DMX, or dynamic digital radiography, DDR. And so that was the goal of this video. It's online right now. I'll try to see if I can go ahead and let me go back and get to, so I'm going to put this, the link to that video in the comments right now. And if you're out of country, that's a great video to give to an X-ray center to try to get something like a DMX. So again, my goal has always been, doesn't matter if I'm ever going to see you, if I can put content out there that will help a lost CCI patient sitting someplace in Europe or Africa or Asia or wherever, figure out if they've got CCI or not, then that's a net positive. Madeline, I got my C1 through 6 adjusted and they all held. I'm still dealing with 24/7 tension, headache, and POTS-like symptoms. Worth getting a DMX. Yeah, Madeline, that's the kind of situation where you would start to look at other things, right? A DMX would be one of those. Movement-based imaging would be helpful here to rule out instability, where that's craniocervical instability or instability elsewhere. Tanya, I've been diagnosed with bilateral jugular vein compression at C1 with styloid calcification. I've been prescribed daily twice Brilinta. I've read the prep for PRP and would need to discontinue that treatment. So I'm assuming that's some sort of newfangled anticoagulant, but we will see here. Yeah, so that's an anticoagulant. So again, telling you, the question's going to be, do you have something that's different than the average person walking around out there? Just to give you a sense of it, if we look at bilateral severe internal jugular vein compression in patients who were undergoing cervical venogram for other things, 1 in 5 of those patients had that issue. They weren't on Brilinta. They weren't on any anticoagulants. So again, the question would be, why are you on anticoagulant? Maybe there's a history of embolic stroke. Maybe there's a history of DVT or other things I don't know about, but all of that needs to be looked at in context, and that could be a telemedicine, for example. Darcy, I'm going to skip that one because I don't know what you're referring to with the ear. Mom, I'm going to see if I can try to get some new people in here just because we're getting close. Stephanie, I have patent foramen ovale, small hole in the heart, and maybe contributing to my headaches as well. Yeah, so I don't know how patent foramen ovale would cause headaches in particular, other than maybe you're talking about a backup venous flow. But again, that's something that would have to be looked at, right? If on hands-on physical exam, it seems like, again, the 1-2 facet joint is causing your headaches, then that's a different pathway than going down the venous path for headaches. It would be awful to spend a lot of time down the venous path, spend hundreds of thousands of dollars of money in treatments and diagnostic stuff, only to find out later it was your C1, C2 facet joint, which is much more common in causing headaches. So I would encourage you to have someone with high levels of musculoskeletal headache expertise. That's probably more physical medicine, rehab, for example, spine specialty, than it is neurology, to see if you have upper cervical issues causing headaches. Brent, when having episodes of dizziness, can CCI also cause paleness in the face, almost like vasovagal? Yeah, Brent, I mean, that's certainly possible, right? If you have any kind of vasovagal, you're going to get paleness in the face. That's sort of the pre-syncope paleness, where you might look at someone and say, wow, you look pale, and then they go down. So yeah, all of that makes sense. Rachel just sent my info in for televisit. I's been great in guiding me. Thank you, Rachel. Look forward to seeing you and trying to break down, what's going on and can we help. Casey, I saw an article that said DSA is not infallible to exclude intravascular injections. Is there any research comparing aspiration DSA to including these mishaps? Yeah, it's definitely not infallible. Nothing is infallible, but I can tell you it's a heck of a lot less fallible than not having it. And that's the biggest problem, Casey. Meaning that 99% of the time when people are getting injected up here, digital subtraction angiography is not used, isn't available. The doctor wouldn't know it from Adam. So it's a heck of a lot more infallible than not having it. You can also try to aspirate, but the problem with trying to aspirate is it depends on where you are. The vertebral artery is not real big. You could be sitting right halfway through the wall of the vertebral artery, and then when you go to inject contrast, it breaks into the vertebral artery, and you see that on DSA. But if you were to pull back on the syringe, you would get nothing. So again, DSA is going to be a heck of a lot less infallible, more infallible than having nothing. And pulling back on the needle or on the syringe is not a valid way that's going to keep you out of court. So the bottom line is you can use the court metric, right? If you have a malpractice case where you inadvertently inject the vertebral artery and you stroke a patient out, and they want $20 million for ongoing care because now that person's a vegetable and the family is coming after you. In court, if you've got DSA, you're probably fine. It's probably something where it's like, you did everything you should have to prevent this, but it still happened. That's not malpractice. But if you don't have DSA, you might as well write a check. meaning just pulling back on the syringe isn't going to protect you in that scenario. So that's maybe a good way to look at it, is to use the court standard. Not every practitioner can afford DSA, should eventually stop foreign spinal injections without DSA. That seems impractical. The only time I think you need DSA casing is if you're doing these upper cervical injections. And then it's a rounding error for those practices, meaning a C-arm that's new that doesn't have DSA might cost you $120,000. A C-arm with DSA is about $135,000. You can get those even cheaper. You can get the Korean machines, usually South Korean machines, for $75,000. They're probably only charge you a $5,000 or $6,000 upcharge. So it's not practical to say that these practices couldn't afford it. That doesn't make much sense. It's a rounding error with how expensive all these things are. But it's only needed if you're injecting this upper cervical spine, or you're injecting to areas where you could end up into vessels that, if you injected, will stroke out the patient. So that would be the reason why you'd want to have it. So again, if you're injecting the upper cervical spine without DSA and you have a problem, I will be happy to testify against you in a court of law, which I don't normally do, because it's very clear that you needed it in this scenario. And if you stroked out the patient because you were too cheap to buy it, that doesn't fly on the stand. Liam, sometimes the pain I feel is sometimes my C1 and C3 getting locked on each other and don't move properly. Is that a common feeling? Yeah, Liam, I think that kind of goes back to some discussions we were having a few weeks ago with Greg Johnson, right? Greg was talking about there can be joints like the upper cervical spine, especially C1, C2, because of the amount of range of motion it has, where some of the range of motion is not available to C1, C2, and the other part of the range of motion is hypermobile. Brent, is dizziness while exercising indicative of CCI and or IJV compression? The dizziness comes paleness in the face as well. Yeah, Brent, lots of things can cause that. So obviously you'd want to get worked up by cardiology. That would be key there, where they can do a Holter monitor or do a stress test so that you can make sure that that's not related to cardiac things. You'd also want to make sure that you don't have any brain tumors, other bad things. But if the bad things are ruled out and that's related to you moving your neck around, then we might look at CCI as a cause of those things. Sasha, is there a way to get around fusion for a fractured facet joint? Sasha, a lot of that has to do with how old the fusion is, meaning if you're talking about an acute fractured facet joint and there's bone moving around in there that might push out and hurt the vertebral artery or hurt the spinal cord or brainstem, then you need a fusion for sure. If you're talking about an old fracture that's probably stable and it's injured the joint, then the goal should be to treat the joint with regenerative medicine and or fix any of the ligaments that got injured at the same time. So it just depends on the kind of things we're talking about there. Anja, does the ponticulus provide any additional obstacle in CCI treatment? No, Anja, we have lots and lots of patients with ponticulus. Just so that people understand what we're talking about here, Anja, what we're talking about is that in some patients, and it's probably 1 in 5 or 1 in 4 of the CCI patients we treat with PICL, there's a bony arch that grows over the vertebral artery as it passes over C1, and that's called the ponticulus. There's lots of names for it, but ultimately, it's not a problem with what we're doing. Sasha, where do you practice and do you read outside radiology? Yeah, I read all of my own films, meaning I do not rely on radiology reports other than to make sure there's nothing really bad going on. But I read my own films because frequently radiology reports, in my experience, miss things. So I read everything. I measure everything on my own, meaning I don't accept that a radiology report, for instance, says the grab box is 11 in a flexion extension upright MRI. I'll measure that myself because there's a new study, Nicholson et al., that the radiologist probably never read that goes into dialing in how that upright MRI grab oak should be done. So I read everything. And I practice in Colorado, and we do telemeds a lot. And then I probably going 5 minutes over here, so just trying to get to as many of these things as possible. Amen. PRP with double centrifuge ozone added to it and then activated with laser. That's a mess. that's what I'll call a gimmick mess. That would be a great video. Amen. So thank you. That's a great video idea. I got to copy that one, and I don't know if I can copy it or not. Maybe I'll just take a. But that's an LOL moment, and I'll tell you why here in a second. I'm not laughing at you. I'm laughing at the provider that came up with all that craziness, because it is just craziness. I will do a video on that. I'm just sending myself a quick note here because that's an LOL one. So yeah, reason why I said it's an LOL one is that there's a lot going on, right? So PRP with double centrifugation. Why would you double centrifuge PRP? You can do that to get the dose up. That's good. Ozone added to it is a nightmare because ozone is cellular destructive. That's how it works. So it'd be like adding prolotherapy to PRP. You're just going to kill the platelets. So by adding ozone to PRP, you are killing the platelets and probably destroying their ability to naturally degranulate because ozone is toxic and caustic. That's how it works as a treatment, just like prolotherapy. It causes a local cellular debridement, local cellular death, and that local cellular death is enough to kick off an inflammatory healing response. But if you add it to PRP, you're going to destroy the platelets, which is a dumb idea. And then activating it with laser is just goggly goop BS, meaning it's a gimmick. There is no laser activation of PRP that's been shown to do anything to PRP that benefits patients. So it sounds like a clinic that's trying hard to focus on gimmick layered on top of gimmick, layered on top of gimmick, rather than just trying to do good medicine to help patients. Liam, do you get many Aussies? Yeah, I get a ton. Liam, I would say right now, as far as, let's see, in Europe, most common patients we get are Britain and Germany. We've got a lot of German CCI patients. And then in your area of Asia and south of Asia, I would say Australia is our number one in that region. Thank you, Sasha, for your vote of confidence. Yeah, amen. PRP is great. There's no reason to add on all the gimmicks and play all the games to try to get attention. You know, high dose PRP for your age. So what that means is that if you're 25, you don't need high dose. You could go with a 2 or 3 times baseline PRP. If you're 40, you do need high dose. If you're my age, you do need high dose. What is high dose? High dose is going to be, depending on your age, somewhere between 10 and 20 times concentrated. That's hard to do with the little kits. That's probably why they were trying to do a double centrifugation, which is fine. But again, when you add in all the gimmicks, one of those gimmicks is making the PRP less effective, and the provider doesn't know enough about PRP to understand that he's actually hamstringing his patients. Absolutely, Liam. I love the use of the word keen in there. It's a very Aussie use of the word keen. And then amen, 29. So you really don't need high dose PRP, amen. You could do with low dose or moderate dose PRP just fine. I wouldn't add ozone, but again, just realize that if your doctor is not with it enough to understand that adding ozone to PRP is going to destroy the PRP, I would find another doctor, meaning you want a doctor that understands the basics of regenerative medicine. And that is, number one, don't add prolotherapy or PRP or ozone to anything in PRP because that destroys the platelets. So I would just find another doctor because that doctor just didn't get the basic memo of how you deploy regenerative medicine. Okay, guys, Seems like we got more people watching as time went on. It's probably because I went earlier. Take this last second here to like this video. Again, I want to see those likes get higher because that's how people find this content. So if you found this content helpful here, if you learned something here today that you didn't know, please like this because that's going to help other CCI patients find it. You know how miserable you are with CCI 6 months from now, a year from now, 2 years from now. There's going to be someone looking for answers to these questions, and they're not going to find them unless you hit that like button. Thanks so much for watching, guys. I will be here next week. I'll be pushing out a bunch of videos. As you could probably see more recently, I've been having a blast creating lots of videos. It's a good, creative, fun thing for me to do that takes my brain out of that medical data mode and moves it into creative zone. So I enjoy doing them. I'll continue that flow of videos out there. So be on the lookout for those. And I'll see you next week. Have a great weekend and a great week. Thank you.